Thank you for joining us on this sepsis awareness course and training. My name is Scott Harding Lister and I am the senior nurse here at Apex Health Associates. We're a practice of nurses that provides, amongst other things, education within the clinical arena. This course is not too long and you can dive in and out of it as and when you wish. At the end of the course, we will provide you with a certificate. If you have any questions, then you can contact me via email, which is included on the screen. In addition, you may also wish to be added to our mailing list about future courses. If you do, then drop us an email and we will add you to our distribution list. Again, and most importantly, thank you for joining us today for this short training. Today, we're going to cover the following areas. We're going to look to see if there is an agreed sepsis definition and talk about what sepsis is. We are going to explore what causes sepsis. We will investigate and describe what the signs and symptoms of sepsis are. Then we'll look at and consider the best practice treatments. We'll look at the National News 2 scoring system, as this is an important monitoring tool within the clinical arena. We will take a look at this and how it is used. Importantly, to close and finish, we will talk about the post-sepsis syndrome, a syndrome which is not talked about often and ill-defined. We will describe what it is, its signs and symptoms, and the treatments available. I have included on the presentation screen an important website for you to take a note of and have a look at. This is for the UK Sepsis Trust. So let us think about what sepsis is and how it's defined. This is not a straightforward question to answer because sepsis is a complex medical condition, and as such, it is difficult to produce a simple and concise definition. There are two definitions that I have listed on the slides. Firstly is the definition from the World Health Organization. They state that sepsis is a serious condition that happens when the body's immune system has an extreme response to an infection. The body's reaction causes damage to its own organs and tissues. Secondly, looking to the NHS website and information, they define sepsis as a life-threatening reaction to an infection. It happens when your immune system overreacts to an infection and starts to damage your body's own tissues and organs. Sepsis is also sometimes called and referred to septicemia or blood poisoning. So both of these definitions acknowledge that sepsis starts as a result of a local infection. It can be any type of infection that triggers the sepsis reaction, and it's this extreme physiological reaction which can cause damage to the body and possibly death. So why all the fuss and talk about sepsis? Why do we need to do this training today? Well, it's difficult to ascertain the exact and actual numbers of patients and people that suffer with sepsis due to the way in which the illnesses are coded within our health service and therefore collected within the UK. However, the Sepsis Trust, who we mentioned earlier, suggests that there are likely to be around 200,000 cases per year, or more likely 250,000 cases. They estimate that there are 50,000 deaths per year from sepsis. The Academy of Medical Royal Colleges suggest a higher figure of around 65,000 deaths per year. This is a significant mortality rate, and sepsis claims more lives than lung cancer, bowel, breast, and prostate cancer combined. Sepsis is a very serious condition, and the key message is that it needs to be spotted, identified early, and for treatment to be commenced as quickly as possible by experienced and competent clinicians.
On the 8th of January 2018, Sean came home from school and he was displaying flu-like symptoms. And he said, "I don't feel well, Ma." I said, "Look, you're off tomorrow, have a rest." I gave him a Lemsip that evening and he went to bed. By Tuesday evening, he'd been talking to his sister Zoe and he said, "I don't feel 100%, he said. So on the Wednesday then, he was due back in school and he said to me, "Ma, I feel rotten." I said, "Okay." So I made an appointment for the GP that morning. GP checked him over. She said he has a bad influenza, high fever, chest infection. I'm going to give you an antibiotic in case it progresses to pneumonia. By Thursday, he was getting worse. By this time, Sean had shortness of breath, mottled skin, couldn't sleep, very, very irritable. And I was watching TV with him that night, and about 11:30, he stopped talking to me. And I knew straight away there was something wrong, and Sean stopped breathing. And I called for Joe, and I had to watch Joe give Sean CPR in front of me while I phoned the paramedics. And at 6:30 on Friday the 12th of January, Sean passed away.
So we knew nothing about sepsis. We never even heard of sepsis before they took Sean from us. Sean had no underlying health issues. He was a happy, healthy young man. You know, since then we found out that there's 15,000 reported cases of sepsis per year in Ireland, leading to 3,000 deaths per year.
You know, people ask me what is sepsis, and the easiest way I can explain to them is if you have an infection from anything and it's not getting better and you're displaying any of these signs and symptoms, even two, admit yourself to A&E and your child or your parent or anyone belonging to you and ask them, could it be sepsis?
We will now look at the pathophysiology of sepsis. I'm going to try and set out in basic terms how sepsis progresses in the next few slides. To start with, and what is interesting to note, is how we don't have an answer yet as to why some people have a sepsis response and yet others do not, who may have the same or a similar infection. It could be that some people have a higher concentration of pathogens and therefore this triggers the sepsis response. Or it could be a genetic factor in play, or it may even be due to the type of pathogen that is involved. We just don't know. It's important to note that sepsis can be caused by any invasive pathogen that enters the body. So the story begins with a pathogen infecting the human body. This pathogen could be a bacteria, it could be a virus, or it could be a fungus. There is then a dysregulated immune response, and it's this response which causes organ dysfunction. Organ failure occurs when there is an increase in metabolic demand, but there is insufficient circulation. In other words, there is a high demand, but due to this process, there is low supply. When an infection enters the body, it is recognized and it will cause an immune response and inflammation. Part of this involves the release of cytokinins and the recruitment of immune cells. In sepsis, this response that is seen to an infection becomes disorganized and dysregulated and can cause physiological problems. In the dysregulated immune response, which we see in sepsis, we know that physiologically there is an increase in the release of nitric oxide. This is an excessive increase, and nitric oxide causes systemic vasodilation, and therefore the vasculature within the pumping system that we discussed earlier will become very vasodilated. Sepsis will start as a local infection, and as we've said, in some people it may progress to this dysregulated immune response or sepsis. Looking to the research, pneumonia accounts for 50% of all episodes of sepsis. Pneumonia being an infection of either one or both of our lungs. The signs and symptoms of a lower respiratory tract infection include cough, high breathing rate, noisy breathing, and sometimes respiratory distress. Pneumonia is usually confirmed by imaging and other clinical investigations. Pneumonia will either be labelled as a community-acquired pneumonia or a hospital-acquired pneumonia. Hospital-acquired pneumonia has a higher mortality, and it's more likely to be resistant to standard antibiotics. There are 450,000 to 700,000 cases of community-acquired pneumonia annually. About 1.2% and 10% of adults are admitted into intensive care. Hospital-acquired pneumonia has a mortality rate ranging from 30 to 70%. Pneumonia does not have to be as a result of a bacteria, but it can also be caused by other pathogens. In recent times, we automatically think of viral pneumonia and viral infections such as COVID-19 or the flu virus, which can cause a lethal pneumonia. However, there are other pathogens as well that can cause a pneumonia and that can be difficult to treat, such as fungi. Next on the hit list of infections is urinary tract infections. These are infections of the urinary tract, and they're responsible for about 20 to 25% of septic episodes. The UTI or infection is caused by the presence and multiplication of organisms within the urinary tract. Infection may spread to the surrounding tissues and also to the bloodstream. The highest incidence of urinary tract infections is within young women, and data suggests that there are between 300,000 to 700,000 UTIs treated in England each year. Around 15 to 20% of cases of sepsis is caused by intra-abdominal infections or problems. Commonly, these arise from the biliary tract, such as cholangitis or cholecystitis, or as a complication of a perforated bowel. Each year in England, there are between 30,000 and 50,000 of intra-abdominal infections. Cellulitis is an infection of the skin or the soft tissue, and these infections, together with bone and joint infections, account for about 10 to 15% of episodes of sepsis. The figures for this are taken from 2016 to 2017, and we know that there were between 110,000 and 250,000 episodes of sepsis due to cellulitis. To note, of course, that this may be a significant issue and concern for the elderly population who are prone to soft tissue infections such as leg ulcers and pressure sores. The presence of a meningococcal rash is suggestive of sepsis. Meningococcal rashes can be extremely diverse and look different on different skin types. The rate of progression can also vary greatly in different people. A petechial rash looks like pinprick red or purple spots on the skin and can resemble flea bites. A purpuric rash looks more like bruising, showing up as reddish purple areas on the skin. Whatever the cause, the presence of a rash which does not disappear when pressed with a glass in the context of suspected infection is a medical emergency, and it needs senior doctor and nursing input. 1% of sepsis episodes are also due to line sepsis. This is where a line, such as a cannula or a central line, have been inserted and the patient develops an infection which can lead to sepsis. This needs to be prevented by good line hygiene and monitoring. Finding the infection that is causing the problem is important so that once it has been identified, the correct clinical intervention and treatment can be given. However, it is worth noting that in 30 to 50% of cases of sepsis, the pathogen is never identified. The infection is usually identified through clinical thorough examination by an experienced clinician, taking a good history and listening to what the patient says and exploring what has happened to them. Ultimately, the experts with any infection will be the microbiologists. They will advise 24 hours a day and will know any particular issues within the local area. We'll now look at a video setting out the signs and symptoms of sepsis. We've now looked at what are the signs and symptoms in an adult patient. Importantly, those signs and symptoms would be different if the adult patient is pregnant. Moreover, there are different signs and symptoms for children. We will go over those signs and symptoms for these additional groups later in this presentation. So now that we've looked at what the signs and symptoms are, what should we do if any of those signs and symptoms are present? Well, somebody who is developing sepsis is likely to be unwell. And if they are unwell with any of those signs and symptoms, then it is advisable to take them for an emergency assessment by calling 999 or taking them straight to A&E. If you are a clinician in practice and one of your patients or residents is unwell and has any of those signs and symptoms, then the person or resident needs escalating to a senior colleague for an urgent review. In my experience as a critical care clinician, sepsis needs senior experienced doctors and nurses involved as quickly as possible in order to make a difference and prevent the sepsis proving fatal. In order to improve outcomes and to offer a memorable guidance, the UK Sepsis Trust has developed the Sepsis 6 Intervention Treatment Guidelines. It includes strategies to control the source of infection and to measure and restore circulation and oxygen delivery, remembering from earlier slides that the organs can be damaged as a result of this systemic inflammatory response, which reduces the perfusion to the organs. It is recommended that the sepsis 6 guidance and treatment pathway is delivered within 1 hour without any delay, as delays impact on the outcome and mortality. So let's look at the sepsis 6 protocol. Step 1. Step 1 is to get senior help and support from a senior clinician. As we have said and discussed earlier in this presentation, patients who are critically ill will undoubtedly do better if they are placed before senior critical care clinicians. Sepsis is complex and needs the intervention of very experienced clinical staff. Experience can help determine the best care and facilitate and coordinate excellent communication between teams in order to facilitate and introduce effective care. So step 2 is to give oxygen if this is required. In this stage, so step 2, we need to make a fast clinical assessment and determine if oxygen should be given or not. In sepsis, there is a critical imbalance between oxygen demand and supply for the reasons that we discussed earlier in this presentation. The general rule is to start oxygen therapy if the pulse oximeter is recording less than 92%, and for clinicians to aim for saturations of between 94 and 98%. However, if the patient or person is critically ill, then they should be given 15 litres, the maximum amount of oxygen, via a non-rebreathe mask with a reservoir bag. When considering oxygenation and administering oxygen, we would always be cautious in patients or people that are at risk of hypercapnic respiratory failure. Step 3 is about sending samples. We would send bloods and include blood cultures. It's always best practice to try and obtain blood cultures before antibiotics have been given. However, we would never wait or delay the administration of intravenous antibiotics in these circumstances. Now is also the time to request and send a full set of bloods, which will include blood glucose, lactate, full blood count, urea and electrolytes, CRP, clotting studies and liver function tests. It may be that during this clinical assessment there are other body fluids which may also need to be sent to determine a cause of the localized infection. Step 4 is about giving intravenous antibiotics. IV antibiotics should be given, and they should be given quickly. Source control should also be considered, such as draining and surgically dealing with any abscesses. We know that antibiotics save lives, and therefore the sooner that they are given, the better. Those antibiotics should be reviewed daily, and once we have some culture and sensitivities back, then they should be reviewed. Step 5 is to give IV fluids. Consideration should be given to administering intravenous fluids. As we discussed earlier, part of the problem with sepsis is that the vascular volume will be reduced due to the sepsis processes that are occurring within the body. Intravenous fluids will increase the volume within the vascular space and hopefully correct this problem. The person or patient's heart rate, blood pressure, mental state, lactate and urine output should be brought to within target range. Of course, we would be careful not to push someone into overload. Step 6 is all about monitoring. Sepsis is a serious and complex condition, causing someone to improve or deteriorate rapidly. Therefore, ongoing monitoring is paramount, so as to identify any changes as and when they occur. The urine output should be monitored, so as to identify any damage to the kidneys, and also to give an indication as to how well filled or hydrated somebody or a patient is. In order to have this level of monitoring, it is likely that the patient will require a urinary catheter. General physiological observations should be recorded, and this is where the NEWS 2 monitoring system is helpful. The diagnosis of sepsis is a clinical diagnosis, and it's based on clinical judgment by an experienced healthcare practitioner. Unfortunately, there is no specific biomarker that we can ask for which will indicate sepsis alone. The NEWS 2 monitoring system is a risk score that is based on 6 physiological parameters. This helps the monitoring and escalation of patients in a systemic and standardized criteria. Local policies will accompany the NEWS 2 monitoring and will include the timing and definition and processes as to when escalation should occur. In general terms, if a patient is scoring 5 or above on the NEWS score, then sepsis should be considered. Here is an example of a NEWS 2 chart. As you can see, the chart is color-coded as to the points awarded. The chart contains the physiological parameters, and the further the recording drifts away from the normal range within each physiological parameter, points are allocated and summed at the end of the physiological assessment. In some organisations, these charts are completed electronically. In other organisations, these charts are completed on paper, and therefore, due to the colour coding system, it is important that they are printed in colour. My own personal observation and advice regarding this monitoring system is that although it is extremely helpful in identifying people that are sick and deteriorating, it should never replace clinical judgment and the gut feeling that clinicians have.
Hello. The National Early Warning Score, or NEWS, is a number that can be calculated from 6 observations or vital signs. These are breathing rate, also known as respiratory rate, the level of oxygen in their blood, also known as oxygen saturation, heart rate, also known as pulse rate, blood pressure, level of alertness, and temperature. You must have all 6 vital signs to calculate a NEWS score. The total score is very accurate in predicting how unwell someone is. Each vital sign should be written down on a paper NEWS chart or entered onto an electronic observation system. If you are using a paper chart, then it needs to be printed in colour so that you can calculate the final score. In NEWS, each vital sign is given a score. The score ranges between 0, which would be normal, and 3, which is very abnormal. NEWS charts are colour-coded to help you add up the correct NEWS. If you are using a paper chart, you must write the vital sign in the correct place. This is because the colour shows you how many points to score. White is 0 points, yellow is 1 point, orange is 2 points, red is 3 points. The maximum news is 20 points. The higher the score, the more unwell the person is likely to be. Carefully add up the scores for each vital sign. If the individual is on oxygen, they score an additional 2 points. Take care when manually adding up the news. Always recheck your work. If possible, check it using a downloadable news app. There are 2 scales for blood oxygen levels. SpO2 scale 1 is used for most people. This includes people with respiratory conditions such as chronic obstructive pulmonary disease, unless you have been specifically instructed otherwise by a doctor. SpO2 scale 2 is for people with specific lung conditions. Only use this scale if you have been told to do so by a doctor or respiratory nurse specialist. Make sure to cross through the scale that is not being used to avoid mistakes. Depending on your local arrangements, different scores will require you to take different actions to raise your concerns. You must know what is normal for an individual and be able to communicate when someone's news is higher than usual. A person with a score of 3 or 4 can probably be managed in the community by local health services. A score of 5 could mean the person is very ill. The person needs regular monitoring of vital signs whilst an urgent review by a doctor or nurse is arranged. If the score is above 7, the review needs to be very urgent. News supports you to raise a concern, but never ignore your gut feeling. If you feel a person is unwell, always tell your manager or a senior colleague.
There will be a local policy which prescribes how and when a patient should be escalated dependent upon their news score. A low score is usually 1 to 4. A medium score is usually 5 to 6. A high score is usually 7 or more. Any score of 3 in one single parameter or a red score is a very urgent issue which needs to be assessed urgently by a clinician. Sepsis should be considered in any patient or resident where the news 2 score is 5 or greater. If someone is admitted to critical care for sepsis, they will be treated with fluid management and resuscitation, vasoactive drugs to reduce the effects of the sepsis, antimicrobial therapy, spiritual support, renal therapy, nutrition, and it may be that additional therapies such as steroids are also given. In my experience, one of the most important aspects of critical care treatment will be the communication with the family and the patient themselves. If someone has had to be admitted into critical care, they will be extremely unwell, and the family will need to be communicated with and for the extent of the illness to be explained to them. The signs and symptoms for children or infants is different to that of adults, as they may have a different physiological response. So how do we spot sepsis in children? A child may have sepsis if he or she is breathing very fast, has a fit or convulsion, looks mottled, bluish or pale, has a rash that does not fade when you press it, is very lethargic or difficult to wake, feels abnormally cold to touch. If you spot any of these signs, call 999 or go straight into A&E and ask, could it be sepsis? A child under 5 may have sepsis if they're not feeding, is vomiting repeatedly, or has not passed urine for 12 hours. Again, any of these signs, then it is advisable that they have an urgent medical assessment. The signs and symptoms for pregnant patients are different to those of adults. Sepsis in the pregnant patient and the patient who has recently delivered is called maternal sepsis. Sepsis is one of the leading causes of direct maternal death in the United Kingdom. Pregnant women are more susceptible to infections compared to their non-pregnant counterparts. Sepsis can be as a direct result of the pregnancy or a non-related factor. As a consequence as to the risk for pregnant women, they are now routinely offered the flu vaccine. The common source for sepsis are within the urinary tract prenatally and genital tract postnatally. News 2 is not designed for use in pregnant patients. There is a modified scoring system and sepsis screening tool that can be used. Tools are not just for the pregnant patient, but also for those within the postpartum period. The sepsis screening tool may consider fetal distress, as this should be treated as an equal trigger. Now, importantly, talking of lactate levels should be interpreted with caution in women that are in labour, as it is normal for them to rise. For expert and further information, then you are referred to the Royal College of Obstetricians and Gynecologists. An under-discussed aspect of sepsis is its recovery, and a syndrome which can occur called post-sepsis syndrome. Patients or people that have suffered sepsis can suffer physical, cognitive, and psychological problems following the acute illness. In my experience, some patients can suffer quite significant issues after they have recovered from the acute physical septic event. The etiology of the syndrome is not clearly and fully understood. However, I have noted more recently, and it seems that the symptoms of post-sepsis seem to be very similar to those described for long COVID. When we look to the literature, it appears that it takes about 18 months to recover from this syndrome. There is a high risk of readmission for somebody who has been discharged as a consequence of an admission for sepsis. Around the country, there is very little specialist follow-up for people who have been discharged from hospital with sepsis. If a person or patient has been within a critical care unit, then there is likely to be a follow-up service, but this is not the case if they have been discharged from a general medical care facility. The UK Sepsis Trust does have a helpline staffed by very experienced nurses who can advise and assist and take referrals. This syndrome has a number of physical signs and symptoms. These include lethargy, poor mobility, breathlessness and chest pains, vertigo, swollen limbs, joint pains, hair loss, dry, flaking skin and nails, taste changes, poor appetite, changes in vision, changes in sensation, repeated infections, and reduced kidney function. However, of equal importance and sometimes more challenging to treat and manage are the psychological and cognitive signs and symptoms which can also be present. These signs and symptoms include anxiety and fear, depression, flashbacks, nightmares, insomnia, post-traumatic stress disorder, poor concentration, short-term memory loss, mood changes, and loss of confidence and esteem. If the psychological and cognitive issues are significant, it may be that somebody will be required to be referred to mental health services for specialist support and intervention. So to conclude today's teaching session, sepsis is a very serious and complex illness. It is an overreaction by the immune system in response to a localized infection. Due to the complex reasons that we have discussed today, it can lead to organ failure and even death. Therefore, of course, early identification and referral to specialist services saves lives and is incredibly important. We have highlighted the signs and symptoms in adult patients and for those that are pregnant and also for children. As for treatment, we have spoken and looked at the Sepsis 6 and commencing this guideline and treatment as soon as possible. Thank you very much for watching this presentation, and I really hope that you found it helpful. Please do email us so we can add you to our mailing list when other teaching sessions become available.